The first step in the treatment of hyponatremia is to decide what kind of hyponatremia we're dealing with. So the moment I get a low sodium on the BMP or CMP, we check the osmolarity, the measured osmolarity. So high osmolarity or osmolarity, it doesn't matter. This is the hypertonic hyponatremia. Normal osmolarity, this is the isotonic hyponatremia. And low osmolarity, this is the hypotonic hyponatremia. And we said we don't worry about this. You don't need to do anything, no workup or treatment. I'm not sure if you will ever see it now with modern lab techniques. Now, high osmolarity or hypertonic, we explained there is a high or there is an osmotically active substance in the ESF. So the treatment simply is to move this, is to get rid of this osmotically active substance. So if it's a critical hyperglycemia, you give insulin. If it's some kind of alcohol, ethylene glycol, methanol, you get dialysis, for example. Most of these people need IV fluid resuscitation with isotonic solution first, and then later on we can switch to hypotonic solutions. So that's the treatment of hypertonic hyponatremia. Now, very important to understand that this kind of hyponatremia, hypertonic hyponatremia, does not cause symptoms related to hyponatremia itself. There is no concern about osmotic demyelination syndrome or overcorrections in this kind of hyponatremia. You do not need to worry about all of that. Here is the real deal and the most common one where we need to worry about hyponatremia symptoms, about the osmotic demyelination syndrome, and whether we need to give 3% NS or not, etc. So any case of hypotonic hyponatremia, I need to recognize how severe, what kind of symptoms, if there is any symptoms. Are we dealing with mild, moderate, or severe? Is it acute or chronic? Is it rapidly reversible cause of hyponatremia? And is there any risk factors for osmotic demyelination syndrome? It's very important you answer these questions with every case of hypotonic hyponatremia to decide the most appropriate treatment. So hyponatremia is considered severe if sodium is less than 120 milliequivalent per liter. Remember this very well. And moderate 120 to 129, and mild above, equal or above 130. Now, one important thing I want you to understand that we really mild hyponatremia, do not worry much about it. It rarely lead to any symptoms. Again, we said rarely you will have any symptoms if there is mild hyponatremia, if the sodium is equal or above 130. Think of other causes. Severe symptoms, seizures, coma, obtundation. So only these consider severe symptoms. Other neurological symptoms, headaches, fatigue, lethargy, nausea, gait disturbances are considered mild to moderate symptoms. And again, let's review the acute versus chronic hyponatremia, which probably you've seen it last video. Acute, again, the hyponatremia that develops within 48 hours, and chronic, the one that has been there for more than 48 hours. The acute ones, we see them in mainly post-operative hyponatremia. After surgery, patient will have a state of SIADH, and if you give them some hypotonic solution or excessive water intake, they may develop the hyponatremia. And these patients usually have a baseline sodium that you can compare to. It will be normal and drop within 48 hours. And acute water intoxication. Most of these patients comes from home, but because we suspect acute water intoxication, we assume it's less than 48 hours. Psychogenic polydipsia, marathon runners, ecstasy use. While in chronic, duration is unknown and no baseline to compare to, especially those coming from home. We consider that chronic hyponatremia, or we have a baseline to prove that it's existed for more than 48 hours. The only exceptions is the acute water intoxication, because they also come from home. But all other cases, we consider them chronic. Now, very important, we mentioned this last video, and I'm going to repeat it here. Acute cause way more symptoms because the brain cells do not have time to adapt. It's way more dangerous than chronic hyponatremia. Chronic hyponatremia, on the other hand, may cause little, if any, symptoms, even with severe degree of hyponatremia, because the brain cells have the time to adapt to that. On the other hand, the risk of osmotic demyelination syndrome in acute hyponatremia, almost nothing, while all the risk is mainly in chronic hyponatremia. How about the risk of osmotic demyelination syndrome? This is very important to understand. We really get concerned about ODS in these cases. Severe hyponatremia plus the correction is more than 8 milliequivalent over 24 hours, and some say 16 over 48 hours. And the highest risk is if the sodium is less than, equal or less than 0.5, there is alcohol use history, malnutrition, and concurrent hypokalemia. Pay attention to these factors because with these patients, you need to be very careful and aggressive in making sure there is no overcorrection. In moderate hyponatremia, rarely we see osmotic demyelination syndrome, except there is two cases where we get worried about it. The first one is severe liver disease, a patient who is pending liver transplant, especially if they get transplant, their sodium may quickly rise, and arginine vasopressor disorders, which is diabetes insipidus. We only worry about osmotic demyelination syndrome in severe hyponatremia, except these two cases here where we worry about it in moderate hyponatremia. So remember that. Now, these conditions are known for rapidly reversible cause of hyponatremia and volume depletion. This is the most commonly encountered, and I struggle a lot with this because by the time we see them in the ED, they already given 1 or 2 liters of isotonic solution by the emergency room, so they correct quickly. Acute SIADH, not the chronic one. Adrenal insufficiency, once you give them steroids, they correct quickly, and thiazide, diuretics, hyponatremia also, they correct quickly. Now, on the other hand, hypervolemic hyponatremia and chronic SIDH, they usually correct slowly, and we don't really worry much about the overcorrection of hyponatremia here. Let's go over the treatment option we use commonly in clinical practice for hypotonic hyponatremia. I'm going to mention them quickly and then detail them soon. Fluid restriction. And fluid restriction, basically, it will decrease the amount of water in the ECF. When we decrease the amount of water here, that means increase sodium concentration. Salt tablets, on the other hand, works by increasing sodium amount and increasing sodium concentration. Loop diuretics, they induce water diuresis, so decrease water amount in the ECF and increase sodium concentration. ADH receptor antagonists, they work by also selective water diuresis and decrease water amount in the ECF and increase sodium concentration here. Isotonic solution works mainly in hypovolemia and volume depletion by switching off the ADH. When they replace the volume, intravascular volume replenishment, they switch off ADH signal, and then less ADH, and that means more water out, less water in the ECF, and increased sodium concentration. Let's discuss fluid restriction. A lot of question I receive that what kind of fluid? Do we just restrict water or all, even electrolyte containing fluids? I always say all kind of fluids. If you just say just water, you're not gonna get an effective fluid restriction. So relieve all confusion and said all kind of fluids, and effective fluid restriction should be 800 or less per 24 hours. 1000 or 1500 cc, I don't think that will be adequate, although can be used in some difficult patients that you cannot no way to have them restrict fluid to 800 cc an hour. And fluid restriction is useful in fluid overload or hypervolemic hyponatremia. SIADH, all kind of SIADH except the one related to subarachnoid hemorrhage. Here they say we should avoid it because it increase or induce cerebral vasospasm. And in excessive water drinking cases, psychogenic polydipsia, marathon runners, ecstasy use when they come with acute hyponatremia. And as we explained, fluid restriction increase sodium concentration by decrease the amount of water in ECF. How about salt tablets? There are two forms we use in clinical practice. The main one is sodium chloride tablets, and the second one is urea. Sodium chloride tablets simply increase sodium concentration by increasing the sodium amount. Each 1 gram of sodium chloride is equivalent to 35 ml of 3% normal saline in terms of the sodium amount. But it's just tablets, no fluids, right? And urea mainly works by inducing water diuresis. So it causes increase in sodium concentration by decrease the water amount. The clinical uses mainly SIADH, the sodium chloride, and mainly in SIADH, the sodium chloride are combined. The sodium chloride is combined with loop diuretics, and also low solute load, like patients in tea and toast syndrome and beer potomania. Although these patients, we can adjust their diet to increase the solute load and not necessarily give them sodium chloride tablets, but that's an option. And mild volume depletion and thiazide diuretics, we can give them sodium chloride tablets as well. Loop diuretics, furosemide, torsemide, bumetanide, they mainly induce water diuresis, diluted urine, unlike thiazide diuretics, which cause concentrated urine, as we explained in our first video, understanding hyponatremia. And that's how they increase sodium concentration, by getting rid of water from the ECF. Clinical uses, of course, volume overload is pretty obvious, and in SIADH along with sodium tablets. So we give sodium tablets to increase the sodium amount in the ECF, and we give loop diuretics to get rid of water from the ECF, leading to increased sodium concentration. Now remember, with urea, we do not use them if we're gonna use urea, because urea induce water diuresis by themselves. So if you decide to use urea, there is no need to use loop diuretics, and I'm talking about SIADH here. Isotonic IV fluid solution, whether normal saline, lactated ringer, we use them in volume depletion only, and avoid please in SIADH or fluid overload. This is pretty obvious. The way it improves hyponatremia in volume depletion is by replacing the volume status or repleting the volume status and then cancel the signal for ADH. How about the vasopressin or ADH receptor antagonist like Tolvaptan and Conivaptan are the only oral ones available in the USA. And it seems this can solve all kind of hyponatremia because it goes and block the ADH from action on the kidney. So regardless of the cause of hyponatremia, because we said hypotonic hyponatremia, all of them for reason or another they have excess ADH, right? We definitely do not want to use it in volume depletion. So avoid in volume depletion, and we mainly use them in volume overload and SIADH. The problem with them, they are expensive and they can induce thirst, which can be a problematic because patients start drinking large amount of water. And whenever you think about using them, I highly recommend that you consult nephrology. Now, FDA, they said we should not use more than 30 days. Do not use for more than 30 days. And they want us to avoid this in liver disease patient. Now, one exception really, if there is somebody with end stage liver disease or liver cirrhosis that going to get a transplant, and we're trying to optimize everything, including hyponatremia, it's okay to use Tolvaptan and Conivaptan. And again, this will be managed by the transplant team. So most likely we're not gonna worry or deal with it much. Now, very important, history and physical exam is 95% of the diagnosis of hypotonic hyponatremia. Please get a careful history and a good physical exam. This way better than urine sodium, urine osmolality, all of this, which can take time to come back. And that's why the history is important. Look, if the patient is coming to you with diarrhea, vomiting, over diuresis, hypovolemic hyponatremia, clear, right? Peripheral edema, pulmonary edema, ascites, hypervolemic hyponatremia, signs of fluid overload. No signs of fluid overload or volume depletion, we're dealing with euvolemic hyponatremia. Now, are we dealing with a marathon runner, ecstasy use, then excessive water drinking, or psychogenic polydipsia? Alcohol abuse, thinks of beer, potomania. An elderly with poor dietary habits, tea and toast syndrome. Suspect SIADH if nothing to point to in the history, or if there is a risk factor for SIADH. If there's severe hypothyroidism, this is probably the culprit of hyponatremia, and if there is adrenal insufficiency. Now, the main challenge that you may encounter is differentiating between mild hypovolemic hyponatremia or mild volume depletion and euvolemic hyponatremia. You're not seeing clear signs of volume depletion, so you think it's euvolemic hyponatremia. Here where it gets challenging, sometimes we deal with it as it's hypovolemic hyponatremia, treat it as such and monitor the sodium. Usually in SIADH, if you give fluid resuscitation, sodium may improve a little bit then drop, but it will not continue to improve. So remember, history and physical exam is the main thing in hyponatremia diagnosis. Acute hyponatremia, ask yourself if 3% is indicated, and we discussed this in detail last video. If symptomatic, regardless of the severity, or asymptomatic that's not improving on its own, again, you can go back to my video. But if 3% is used, should be discontinued once the 4 to 6 milliequivalent rise of NA level of sodium level is achieved. The daily goal should be 4 to 6 and 8. If you want to be really conservative, you can shoot for 4 to 6, but you can go up to 8 milliequivalent per 24 hours or 16 milliequivalent per 48 hours. The sodium level should be checked 1 to 2 hours while on 3% until 3% NS until the level has increased by 4 to 6 milliequivalent, whether 3% normalsin is used or with autocorrection. Then after the 4 to 6 milliequivalent improvement, you can change it to every 4 to 6 hours. Now, the treatment, water intoxication, acute water intoxication, marathon runners, psychogenic polydipsia or ecstasy use, institute fluid restriction to less than 800 cc a day, or every 24 hours as we explained, and increase their dietary solute load. So you need to change their diet because most of these people drink too much water and they have very poor dietary habits in terms of solute load. Or you can give them sodium tablets, sodium chloride tablets if you wish to. Post-operative hyponatremia, immediately stop any hypotonic fluid solution and treat the underlying SIADH because this is related to surgery-induced, post-operative induced SIADH with a fluid restriction. And as I said, sodium chloride tablets and loop diuretics as we will come to SIADH. Now, about in chronic hyponatremia, again, last video, I will review it here. 3% normalcy is indicated severely symptomatic or the presence of intracranial pathology or severe hyponatremia less than 120. And this is probably the most common reason we use 3% NS in clinical practice. So please refer to my old video. If 3% normalcy is used, it should be discontinued once the 4 to 6 milliequivalent rise in sodium level is achieved. The daily goal again, 4 to 6, you can shoot to 8 or 16 milliequivalent per 48 hours. And the sodium level should be obtained every 1 to 2 hours while on 3% normal saline. Once off 3%, you can go up to 4 to 6 hours. Now let's have some details about some of the causes of chronic hyponatremia. Now the first thing come to my mind whenever I see hypotonic hyponatremia, I ask, is the patient is a dialysis patient, end-stage renal disease on dialysis? And if it is yes, this explains everything. So you can, of course, fluid restriction and of course dialysis, hemodialysis. If there is any emergency, just consult nephrology to perform emergent dialysis. So this is the first thing I check whenever I see hypotonic hyponatremia. The second thing, immediately I look at their home medication. Do they take any thiazide diuretics? And if they do, if I see any degree of hyponatremia, I discontinue this indefinitely. One of the mistakes I see them all the time, they come to the ED with mild hyponatremia, they send them home without discontinuing hydrochlorothiazide, they come back with more severe hyponatremia. So remember this, indefinitely for thiazide diuretics. This is a rapidly reversible cause of hyponatremia, so they can correct quickly. And most of the time, I tell you, when I come to the ED, they're already giving 1 or 2 liters of isotonic solution. But if I get to treat them from the get-go, I will not give any isotonic fluid solution unless there is signs of hemodynamically stable. What you can do, give them salt tablets like sodium chloride tablets, replete potassium if hypokalemia exists, and avoid isotonic fluid resuscitation or solution unless there is clear signs of volume depletion, severe volume depletion or hemodynamic instability. And remember, on discharge, do not resume hydrochlorothiazide diuretics. The next thing, if the patient with hypotonic hyponatremia is not on thiazide or dialysis, I come to this. What's causing the elevation or the excess ADH? Is there signs of fluid overload? Then this is hypervolemic hyponatremia. And simply here you need to give loop diuretics plus fluid restriction as we explained to less than 800 cc. Plus you need to do sodium restriction, and we explained, we said sodium amount, the total sodium amount in the body correlate with volume status. So we restrict their sodium intake to less than 2 grams per day. So low sodium diet. The next thing is the other contrary, the volume depletion. Here simply you need to replace the lost volume, fluid resuscitation. And remember, this is a rapidly reversible cause of hyponatremia, so we need to be careful. The next thing is SIADH, which I will explain next. And severe hypothyroidism, of course, you will have symptoms to guide you there. And you can easily diagnose this with labs. And the treatment is thyroid replacement hormone therapy and adrenal insufficiency. And again, the treatment is steroids here. And both can be rapidly reversible cause of hyponatremia. So we need to be careful. SIADH, again, we need first with SIADH is to treat the underlying cause. Very important not to forget, look for the underlying cause and treat it, whether it's a condition or a drug that you need to discontinue. The treatment with fluid restriction, again, less than 800 cc of all kind of fluid. NaCl or sodium chloride tablets, and again we give them with loop diuretics. If you decided to give urea oral solution instead, there is no need to give loop diuretics because they induce water diuresis themselves. And arginine or ADH receptor antagonists, we said like Tolvaptan or Conivaptan. And the last one here, the low solute load. And again, we see it mainly in T and TOS syndrome with mainly elderly. So we adjust their diet, modify their diet to include more solute, more sodium, more salt, and restrict fluid if excessive water drinking. For beer potomania, most of these people drink a lot of alcohol, drink water, and very poor diet, so we need to counsel them about alcohol, increase solute load in their diet, and restrict fluid if excessive water drinking. Overcorrection, I mean here by increasing sodium more than 8 milliequivalent within 24 hours or more than 16 milliequivalent in 48 hours. I prefer to follow this rule. Avoid, please, as we explained earlier in this video, avoiding chronic hyponatremia in those with rapidly reversible causes. Remember, volume depletion, thiazides, acute SIADH, and adrenal insufficiency, or those with osmotic demyelination syndrome risk, sodium less than 120, severe hyponatremia. The risk is much higher if sodium less than 105, alcohol abuse, patients with alcohol abuse, malnutrition, hypokalemia, unless severe liver disease and diabetes insipidus, 120 to 129, you need to worry about that. This is very important and will relieve a lot of confusion and headache when you treat these patients. Let's talk about overcorrection management and the predictive formula that people use, which you can access online. I'm not going to mention them here. The one important thing I want to mention, they can miss a lot. They are inaccurate, but they can be used to help you if you think there is maybe an overcorrection, and they will help you slow down the therapy from the get-go. I usually don't use them, I just follow the sodium level, but you can use them. Let's say you plan to give 2 liters of normal saline and you want to see how much sodium correction that will give you, and you see it exceeds the limit for that day. So in that case, you can slow down the therapy and it will help. But again, do not rely 100% on them. Now, the management strategies of overcorrection is either proactive, reactive, or risk. What do I mean by that? Proactive, that means you expect the overcorrection will happen from the get-go before you start the treatment. And this happens when you have a rapidly reversible cause of hyponatremia and you're planning to use 3% NS. In such cases, we advise to start the slowing therapy, if I can say slowing therapy, at the same time you start the 3% normal saline, not after. And that's what we call proactive. Now, reactive, on the other hand, you started the treatment of hyponatremia and the next sodium check shows some increase in sodium level, and the increase was significant enough that you think it will exceed the daily limit. Let's say the sodium was 117, for example, and then the next sodium check was 124, and this, let's say, was in 6 hours. So you can see that the sodium jumped about 7 milliequivalent in 6 hours. So for sure in 24 hours, it will exceed the 8 milliequivalent, right? So you start slowing therapy, and that's what we call reactive. Now, rescue, from the name that, let's say the sodium was 117 and the next sodium level was 127, let's say in 6 hours, right? So you already exceeded the daily limit. So you start the rescue therapy, start slowing down. You want to bring that back to less or equal 125 to keep it less or equal 8 milliequivalent per that day. Unfortunately, most people use the rescue strategy, less use the reactive strategy, and very few use the proactive strategy. Let's talk about desmopressin. Desmopressin is an ADH analog given as 1 to 2 mics IV or sub-Q every 6 to 8 hours for the first 24 to 48 hours, or until sodium level is equal or more than 125. Remember that. So once the sodium, this is the safe level, I call it. Once it's there, we do not really need to worry or use the slowing therapy. We do not need to use the desmopressin. And remember this is very important. Restrict free water intake when desmopressin is used, and avoid it if water cannot be restricted, like somebody with psychogenic polydipsia. You think he cannot control his water intake, then you should not use desmopressin. So the proactive strategy that we explained last video, you can refer to that video. We use, as I said, if we're using 3% NS and we're using in a rapidly reversible cause of hyponatremia, desmopressin 1 to 2 microgram IV sub-Q, Q6 hours, plus 3% normal saline 0.25 per kg per hour. Let's say we have a patient who's symptomatic. We decide to give 100 cc of 3% NS. We give it times 3, symptoms resolved, and the sodium increased by, let's say, 6 milliequivalent. Remember the goal 4 to 6, because most of the time this will relieve symptoms. Now I'm afraid with further therapy, this sodium will correct really quickly. So what you could do is, okay, I'm gonna, let's say the patient is 100 kilo. So you can say this, I'm gonna use 3% NS 25 cc an hour plus desmopressin 2 mcg IV Q6. And you continue checking sodium every Q4 to 6 hours. Most of the time, this will give you controlled rise of sodium without concern of overcorrection. Let's take an example of the reactive approach. Here, 82-year-old gentleman with weakness, poor oral intake, history of CHF on furosemide, spironolactone, lisinopril, diagnosed with UTI. There is no edema on physical exam. Initial sodium level was 109, potassium 4, initial BUN and creatinine 48, 2.9, and normal BUN and creatinine at baseline. So I come to see this patient. The patient has severe hyponatremia, chronic hyponatremia. So that's an indication to give 3% normal saline. And also he has a rapidly reversible cause of hyponatremia because he's clearly volume depleted. Now I come to the ED and I found that he received 2 liters of normal saline IV boluses in the ED. The first thing now I suspect, they gave him this fluid, so probably this will cancel the ADH signal, right? And may lead to quick improvement in sodium level. Immediately I obtain NA level stat, and then I found this was at 115, and this was in 2 hours. So there is 6 milliequivalent improvement without even giving 3% normal saline. So my goal is to keep it for the next 24 hours, should remain equal or less than 117, right? Or even less. So now I expect this will definitely exceed this. The way we do it here, multiple ways. The easiest and most efficient one is to give desmopressin 2 mics or 1 mics IV times 1, then check NA level in 4 to 6 hours, and then you can repeat another dose. You can give it every 6 hours to keep the sodium equal or less than 117, okay? Once you achieve that, you can stop desmopressin and continue monitoring sodium and treat accordingly. Now, another approach is to give D5W and equal it to the urine output. You monitor urine output, whatever urine comes out, you give back D5W. The easiest one is free water to match urine output. So this is, and I've tried this before and it works well, but desmopressin to me remain the most effective way. Let's finish by the rescue approach. The night float team admitted a patient with sodium level of 117 secondary to volume depletion. Next morning, the patient received fluid overnight. So next morning, 8 hours after the first sodium, the sodium is 127. Patient weight is 70 kilos. So we already passed the 8 milliequivalent per day or per 24 hours in 8 hours. So the first thing, DC all kind of fluid that the patient is receiving. So we have full control. The second thing we need to do, desmopressin 2 mcg IV Q6 should be started, and then D5W. And the guidelines or recommendation I've seen up to date saying 6 ml per kg of lean body weight. So lean body weight, if this is a male patient, probably be around 50 something. So that means you probably talking about almost 400 ml. And they say infuse it over 2 hours. I mean 200 ml of D5 per hour. People may call you back, say, hey, this is too much of D5W. But if you are concerned, you can start 150 ml per hour of D5W along with desmopressin. You need to monitor the sodium at least every 4 to 6 hours. You just want to reach the daily goal of, let's say, I want to drop. The goal would be to drop the 127 to 125 or less. That way 8 milliequivalent for the 24 hours. Sodium of equal or more than 125. This is the number that we do not need any more desmopressin. We do not need to worry about ODS once we achieve that, but we should achieve it. But we should achieve it at the pace of 8 milliequivalent per 24 hours. So say 110. I want to go to, let's say, 117 and then 125, not to jump 125 immediately. And this is a safe level that above that you can think of discharging patient as well. Mild to moderate asymptomatic chronic hyponatremia can be managed outpatient. And you would be surprised because we get to admit most of these people sodium 122, 123, 124. I'm not saying do not admit them, especially if they come in with an infection, poor oral intake, all of that, etc. But if they are stable, they have good oral intake, there's, let's say, maybe just HCTZ, you can stop that with clear instruction, they can be discharged. Now, if the patient is still on desmopressin, the patient should be off desmopressin at least for 24 hours with stable sodium level before discharge. The same thing if you started ADH receptor antagonist, Tolvaptan or Conivaptan, they should be in the hospital for additional 24 hours since starting them to monitor their sodium level and adjust their dose. And again, if you decide to use them, consult nephrology if available. In the end, if you found this video useful, hit the like button and share it with your colleagues, please. And remember to sign up for video summary if you have not done so. The link to my Substack is provided below. Thanks for watching and see you soon.